organizing committee for having me here in this meeting. It's always a pleasure to come to Bangkok. I should clarify that this is not all strategies, but rather very selective alternate strategies to treat delayed and immediate type 1A endo leaks. We know that it's quite a problem in EVIS, especially now that we're pushing the envelope and trying to do EVIS with short necks, funnel necks, angulated necks, and as you've seen the fantastic cases by Professor Prasit, difficult cases. But increasingly, we found in our practice that the more we try to push this envelope, we have to deal with this problem of type 1A endo leaks. And I think the problem with this is when you're trying to do the case and you see a leak, and then you spend an increased amount of time trying to detect the problem and trying to treat it, trying to characterize it, and it becomes a prolongation of what would otherwise have been a very simple procedure. I think the traditional approaches we all know, put extension calf. In old days we used to put a pump stent, but not always very successfully sometimes. Sometimes we convert immediately to a chimney EVA. Of course, it requires additional access, but may not still seal the leak completely, meaning we sometimes see still gutter leaks. And then in our practice, we try not to extend chimneys if there are more than 3 chimneys. 2 would be ideal. But in some cases, you really have to go all the way up, and then you think about converting to an elective procedure later on with a fenestrated device and bring the patient back. To be perfectly candid, in private practice, it's very difficult. Once you go in and patients find this, they usually lose a little bit of confidence in your ability if you have to bring them back later. So then clearly we have moved on to generations of stent grafts to address this problem. We've all seen in this meeting the Ovation, which is a good O-ring system to seal, but of course it's limited by the maximal diameter of the neck and unsuitable for angulated necks. We all know about the Nalix. It was touted as very good to seal these leaks as well, but again unsuitable in certain angulated necks. And then now a lot of us are trying the Helifix. Again, unsuitable in angulated necks because of the application of the staples. But in our minds, I think it prevents grafts from migrating, but sometimes does not completely seal a type 1A endo leak depending on the anatomy. So this is what I mean. We have a 1A endo leak with a deficient wall coverage in such a case. We're trying not to sacrifice the renal, and you can see it's quite a massive leak. So we tried putting an extension piece plus a left renal chimney that sometimes works very well, but sometimes we still have a very persistent gutter leak, and then what do you do after that? So in old days we used to put a pump stent, it's very good, but what we found in our experience is over time the neck region may undergo a dilatation, and then you develop a new 1A endo leak some years later. And then the problem is you really have jailed the visceral artery sometimes, and the mix coming in back in to do an extension, be it a fever or a chimney, a little bit more difficult. So we thought about doing a new different concept, and we borrowed it from brain aneurysm coiling. How about coiling and glue embolization in the actual process if you think you're going to experience type 1A endo leak? And the idea is that coils are thrombogenic in nature and eventually progresses to promote sac thrombosis. And we use a combination of coils and glue as a leak point, and we identify, whereas our toolkit is relatively simple. We use a soft wire 4 French catheter and a microsystem, and we use detachable coils, sometimes a Nestor, and then we use either NBCA or Onyx, and we use a short sheath. And we select cases that are not suitable for chimney or fenestrated, usually emergent cases. Some of the visceral arteries are in close plane together, or more than 3 chimneys, and cases that somehow we find are not suitable for the newer type 1A endo leak devices. And I think the key is to anticipate the potential for a leak. And what we do is we maintain access to the sac, and we'd like to put a wire access outside of the stent graft after deployment, and then from there a catheter and a sheath as well. Sometimes, so basically if your whole delivery system goes up, we park a wire outside the delivery system, and we do it percutaneously. Sometimes we puncture the side sheath or the main sheath valve, but we find that bleeding is a problem and interacts with the stiff wires. So a typical case like this, we had a case with a marginal neck, and we helifixed it. But we anticipated there may be a problem, so as you can see, we park the excess wire out while we go on and deploy the contralateral limb. And then we proceeded to do the helifix. But post, as you can see, we still had a leak. And in this case, what we do is through that excess wire, we put in a 4 French Bernstein outside the whole system, and then we started with coils and then glue slowly exactly at that point. And as you see, it works